Thank you all for coming today. I'm going to talk a little bit about what NIH is doing in the area of precision medicine, and specifically the Precision Medicine Initiative, and I'm going to try to slide that over. I think that the different names out there, personalized medicine, precision medicine, stratified medicine, targeted therapeutics, they really all are getting at the same general area, which is how do we find solutions to the problem that so frequently vexes us, which is that either we or someone we love ends up with either a problem where there is no clear diagnosis, so you don't know what the path ahead is, or with a diagnosis but no clear intervention or therapy, or having tried any number of therapeutics ending up having a relapse and no clear path forward. And so precision medicine is really an effort to try to get the understanding that we need in order to develop the therapeutics and preventive approaches that we need. So it is exciting. It's a very exciting time right now. We're almost at the 6-month mark since the President of the United States announced the launch of the Precision Medicine Initiative. He did that in the State of the Union on January 20th and then had a White House event on January 30th. We hadn't exactly known whether or not precision medicine was going to end up in the State of the Union address, and so we were all gathered together with the appropriate libations. And when he got to, he said, "And tonight I am launching the and we all erupted and didn't actually hear the entire thing. We had to go back and watch the video. It was really fun. It was really fun. So now we are in a very, very intense planning period. And I have the most responsibilities for the planning effort around the cohort, which I'll talk a little bit more about. But the research components of the Precision Medicine Initiative are really twofold. One focused in cancer, which I'll say a little bit about, and the other on this large national cohort. Of course, equally important to the research component is making sure that we have the appropriate policy infrastructure to enable the Precision Medicine Initiative to proceed and for the findings from that to be translated into meaningful new drugs, diagnostics, and the like for people to benefit from that. So the President proposed for the FY16 budget $200 million for the National Institutes of Health, and we are very hopeful, in fact, that that will appear in the FY16 appropriations. Also, investments in the Food and Drug Administration, which my colleague Sally will talk about, and also in the Office of the National Coordinator for Health IT. And the data infrastructure issues around both cancer and the cohort are quite significant. So let me say a word or two about the Precision Medicine Initiative focus on cancer. Many of you may have seen the article actually on the front page in the Washington Post about a week ago announcing the launch of the NCI match clinical trials. It was sort of interesting. I don't think we could have gotten that on the front page of the paper if we had tried, but there it appeared on the front page of the paper, indicating a very slow news week, frankly, because usually you want to do the reporting of the clinical trial at the end when you have some data. Nonetheless, what NCI will be leading in the Precision Medicine Initiative focused on cancer is expanding the NCI match clinical trials and including, importantly, a pediatric component to that. And so that's an important new addition. The goals will be to identify new cancer subtypes and, importantly, to understand the cause of drug resistance, something that has befuddled us for quite some time. And when we come up with targeted therapies, we are really excited about that, and you'll hear more from other speakers, but too often the cancer outsmarts the drug and our bodies and is able to get away with its deadly deeds. So the cohort part of the Precision Medicine Initiative is intended to be a national research network of 1 million or more volunteers. And really, in order to do this, we need inpatient patients who are willing to provide their genetic information, their biological information, their behavioral information, and the like, in order to provide a really rich resource for researchers. Unlike some research efforts that we have undertaken in the past, this research effort is really going to be built around a partnership with participants from the get-go. both in the design and implementation of the cohort, and also in receiving information from the study itself. So whether that be what research was conducted using my specimens and my information, what findings have been identified from that, and specifically individuals' own personal research results. So that will present some real challenges for us, but I think it's also one of the reasons why people are particularly excited about participating. So putting together a national research cohort is not a new idea. In fact, in 2004, Francis published a paper, I think it was in Science, proposing a gene and environment large cohort. At the time, he proposed that it would be 500,000 people. But the time really wasn't right, and the idea never got completely off the ground. And the reasons for that were because the technology had not yet advanced to a place where we could do this in an affordable way. So if you think about where we were in even information technology in 2004 as compared to now, 11 years later, it's a whole different world. So sequencing cost has plummeted, the time to sequence has plummeted, the electronic medical records didn't exist in 2004 and now are ubiquitous. And then our ability to interact with one another and be able to provide information about ourselves has really been transformed with smartphones and Google and everything else. So it's a very different place from which to start, and the ideas of how you could collect this information really begin in a very different place. So we are in the process of working very hard to build the plans for this cohort, and we hope to have a draft blueprint for consideration of the advisory committee to the NIH director by September, which is a real sprint to put together a concrete plan. We have a blue ribbon panel who's working on that, co-led by patient advocate Bray, Patrick Lake, myself, and Rick Lifton, the chair of genetics at Duke. And so we're looking really carefully about what do we have and what do we need from electronic medical records and existing cohorts. What do we have and what do we need in terms of health, wearables, environmental sensors, and the like. And then what do we need in terms of the genomics? What do we start with? What do we seek to get over time? And then also tapping into the new capabilities around data science. So we are really in the planning phases and hoping to get as much input from all of you and others as we move forward about what's important to do in this cohort, what policy issues are raised, what special populations do we need to make sure to include, et cetera. So we have an interactive website that was launched on Friday, asking specifically for people to feed in ideas about what research questions would you most be interested in having addressed in the cohort and having capabilities to answer within the cohort in the near term. We also have put out now several requests for information, one about sort of to existing cohorts and healthcare delivery systems about their capacities to provide a recruitment base for us. And then now a request for information is out talking about how do we reach out to individuals and communities to make sure that we can engage and be as diverse and inclusive of all of America. So we have 2 workshops coming up. They're going to be webcast and open to the public. The next one is July 1st and 2nd on participant and community engagement. That'll be at NIH. Registration is open on our website. And then a couple weeks later, on July 27th and 28th, we're going to have a workshop on wearables and health devices in Santa Clara, California. So please chime in and share with us your thoughts about this. And with that, I will sit down and turn it over to my colleague, Sally.